distinguished guest speaker, Dr. Fatima, with us. We would like to thank her for her precious time and efforts. She's pediatric oncologist at NIC, in this hospital. And I'll just very quickly go through a little bit of our journey, PNMDP journey, and let you guys know how much we have done so far, not without your help, not without your appreciation. So we are Pediatric and Neonatal Multidisciplinary Developmental Program of Pakistan. What do? We help FCPS, MCPS trainees in their skill development and through conducting sessions, workshops. So our main aim is to improve skills and knowledge of our trainees and also to refresh knowledge of pediatricians and neonatologists, because there are many pediatricians who tell us that they actually join our sessions and they get to know so much about it, refresh their knowledge through these workshops and sessions. Our team, a team of wonderful members, and our founder, you all know very well, now a household name, Dr. Ayaz Ahmed. And more and more people are joining in. That's really very good. So the June 2021 session, we already had one of our sessions with Dr. Meher. And this is our second session for the month of June, which is Approach to Abdominal Mass by Dr. Fatima Ambreen Imran, consultant pediatric oncologist at Indus Hospital. We thank her again. And our second session is going to be yet another very informative long case on leukemia to be discussed by Dr. Syed Habib Ahmed, Assistant Professor, Pediatric Oncology Unit, NICH. Then we have pediatric ECG case-based discussion. This session you should attend. It's very important, packed up with all the information that is needed to ace the talks. And it will be carried by the Assistant Professor, Dr. Muhammad Mohsin, Pediatric Cardiology Unit, NICVD. Then we have our PNMDP interesting case competition. This is the first of our series. So we have a number of cases that are being selected. We have a list of a panel of distinguished judges who would select amongst those cases the best ones. We have a first prize and second prize. The first prize is, I guess, of 10,000 rupees. The second prize is 5,000 rupees. It's going to be a very, very informative and interesting session. So don't miss that. Pediatric hematology BCQ test with explanation would be coming towards the end of the month. Then we have respiratory emergencies to be discussed by Dr. Sunita. She is the assistant professor at Khan Hospital. Towards the end of June, we also have basic neonatal skills course workshop. Now, this is the first ever workshop in Pakistan to be approved by RCPCH. So this is something which is a huge feat for PNMDP and for all the trainees. You would get RCPCH recognized CPD points awarding certificates. We already have selected our participants for this one. So, and the last session of the month would be on poisoning, approach to poisoning by Dr. Kurutalan Bushra Noor, consultant pediatric emergency medicine in this hospital. So more and more people are coming in. Please turn off your microphones. And yes, you can. So you can watch all of our sessions on our YouTube channel. We upload these sessions promptly. If you miss it due to your duty or something, you can easily watch us. Again, You can join us as member. The requirement is to be an FCPS cleared pediatrician and happy to work voluntarily at least half an hour. It's just to say, like, obviously volunteer work is something that you do after you have done your professional duty, but it is something to really enjoy. You can contact us if you're interested at our Gmail address. It is our website is in our last stages of development. This is just an overview of how our website is going to look like. Yes, on our website, you can contribute in our short and long case sections, on our video and image section. We have pretty lot of things on our website. You can contribute to us by emailing us your content at pnmtp@gmail.com. Obviously, we'll go through all those stuff. We'll go through your content, and then we would place it on our website. I've already talked much about this RCPCH recognized workshop. You can also join us as a trainee. If you are not a pediatrician yet, you would be, inshallah. But if you are not a pediatrician yet, you can still join us as a trainee. We'll be discussing it in a couple of more sessions, and why to work as a volunteer in our organization. So the survey on today's session, I'm going to post this link at the end of our session. Please do fill this form because it helps us to improve our sessions. I'll be posting this link very soon towards the end. Dr. Fatima, the mic is over to you. Thank you once again for your time. And you can share your screen now. Please turn off your webcams. I would request, if you don't turn off your webcam, I would have to just block you then, because we don't have any other choice. Please turn off your webcam. Yes, Dr. Fatma. Dr. Fatma.
Assalamu alaikum. Yeah.
Oh, okay.
Is my screen is shared to all of you?
Yes, we can see it clearly, Dr. Fatma, and your voice is clear as well.
I am Dr. Fatma. I am working as a consultant at Indus Hospital in Pediatric Oncology Department. And today's my topic is approach to abdominal mass. First of all, we have to count the overall view. First of all, the distribution of the childhood cancer, what percentages of different cancers in child age group we have to know. Then we can make our differential diagnosis on the basis of history and examination, and then approach for investigation. And how to approach for abdominal mass? According to the abdominal quadrants of the abdomen, we will study that. And when to suspect a malignancy, when patient presented with an abdominal distension or a mass, and how to approach a patient with detailed history and examination to reach differential diagnosis. And then finally, the approach for the workup for definitive diagnosis. And then in the end, we have some cases for discussion. So this is the pie chart which show the distribution of the childhood cancers. And the most common cancer in childhood is the brain tumor. And then after the brain tumor, in solid tumors, the most commonest extracranial tumor is the neuroblastoma. As you all know that the neuroblastoma may arise from the adrenal gland or either due to peritoneally from the sympathetic chain nervous system. And other than the neuroblastoma, the second most common solid tumor is the Wilms tumor, which usually arises within the kidney. And sometimes it may arise outside the kidney, and it is referred to as extrarenal Wilms tumor. And the other tumors include the lymphomas, sarcomas, and the other tumors like germ cell tumor, retinoblastoma, and osteosarcoma with decreasing frequency. And the other tumor, like in liquid tumors, like the leukemias, which are also very common in pediatric age group. So what are the different causes of the abdominal distension along with the palpable abdominal mass? First, we have to know the quadrant distribution of the abdomen and what are the viscera which are present in these quadrants. So we can easily make our differential diagnosis if the different quadrants. So if
Hello, Dr. Fatma, are you there? I think we have lost Dr. Fatma, and we'll just try to connect to her. I would really appreciate if every one of you stay connected to us. So, good news is Dr. Fatma is back with us. Dr. Fatma, can you hear me?
Yes, I can hear you.
Thank you, Dr. Fatma. Thank you.
So we'll continue from where we have left. If the mass is palpable in the right lower quadrant of the abdomen, then you have the differential diagnosis of the tumor may arise from the adrenal gland, like the neuroblastoma. That is the most commonest tumor of the adrenal gland region. And in the lower abdomen, especially in the pelvis, the tumor from the soft tissues that is called as rhabdomyosarcomas, from the skeletal muscles or from the other soft tissues. Ewing sarcoma, which may be primarily from the bony in origin, from the pelvic bone, or either from the soft tissues of the pelvis. And the lymphoma can be identified anywhere in the abdomen. And especially the germ cell tumor, especially the gonadal germ cell tumors like ovarian or testicular tumors, may present with an abdominal lymph. So if the mass is palpable in the left upper abdomen, so you can have the similar differential diagnosis of the tumor from the kidney, from the adrenal gland, or from the abdomen of other abdominal viscera like the gut, from the stomach, or from the lymph node. And if the mass is palpable in the lower left abdomen, so you can have the similar differential diagnosis. So what are the considerations, especially in history and examination, you have to look for and pay attention on the points on history. First of all, the age of presentation is very important to make a differential diagnosis if a patient is presented with an abdominal mass. If the tumor is presented in a neonate at birth or few days within infancy or in childhood, you have different differential diagnosis. Or gender is very important also, because some tumors are more and in history especially, you have to first of all identify the presenting points and detail history of these presenting points, and after that you have the systemic review and identify the associated symptoms in other systemic organs to identify the abnormality in other organ functions due to the mass effect in abdomen. Birth history is very important because if a child is presented at birth with an abdominal distension or palpable mass, so you have to look for the perinatal screening ultrasound, and if there are finding in antenatal ultrasound like an abdominal mass in the fetus, which may arise from the adrenal gland, or there may be history of polyhydramnios or oligohydramnios. And at birth, you have to look for certain congenital anomalies which were associated with tumors, especially the Wilms tumor, which is associated with the Weger syndrome. As you all know that the Weger syndrome include the Wilms tumor, A for aniridia, G for genitourinary abnormalities, and R for mental retardation. It is especially associated with Wilms tumor and other tumors like Denny's-Rash syndrome, which is also associated with Wilms tumor. Beckwith-Beaman syndrome. This syndrome is characterized with hemihypertrophy, organomegaly, macroglossia, omphalocele, and it is associated with different type of cancers in a child, like adrenal tumors like neuroblastoma. Renal tumor include Wilms tumor, and also associated with hepatoblastoma, which arises from the liver, and other syndrome like the familial adenomatous polyposis coli syndrome. It is especially associated with adrenocortical carcinoma arises from the colon. Past history and surgical history is very important, and the previous treatment which have been received by the patient is very important. And after the complete history, you have to look for the physical examination. It includes the local examination of the abdomen and also the systemic examination with associated findings. First of all, you find the abdominal distension. The clinical symptoms are produced by the mass effect or abdominal distension. On examination, you may have a mass palpable or without a palpable mass, you have the effect of mass effects with disruption of the other systemic organs. Like genitourinary symptoms with altered bowel habits and urinary habit, gastrointestinal symptoms like abdominal pain, constipation, vomiting, and other symptoms. Symptoms of acute abdomen, especially in condition with large mass in the abdomen that causes acute or subacute intestinal obstruction, which may lead to an acute abdomen-like condition. Other manifestations of abdominal disease, you have the symptoms of bone pain. If the patient has metastasis of the primary tumor into the bone marrow, it will lead to the bone pain. And the history of pallor, or on examination, you find the patient is looking pallor or having anemia. So it may be a secondary due to a tumor or maybe due to involvement of the bone marrow. And you also have to look for the lymphadenopathy in the peripheral lymph node, either cervical or axillary, inguinal. These are the peripheral lymph nodes. And other lymph nodes like within the abdomen and the pelvis, they may produce an abdominal mass if they are large enough in size. Evidence of bone marrow on the peripheral side, which may indicate that there may be the bone marrow involvement with thrombocytopenia. Constitutional symptoms like fever, malaise, weight loss, malnutrition, and secondary infections, which may be present in patients with advanced stage of disease. Other physical findings which are very important with abdominal examination, you have to look for the genitals and also the perineum. If the perianal orifices are very important to identify any congenital anomaly, any associated feature at the perianal site, the ambiguity of the genitalia, asymmetry of the scrotal region like the testicular asymmetry. These are very important points you have to look in examination. So, how do you evaluate the patient? First of all, the thorough history, as we have already discussed, the physical examination, detailed local and systemic physical examination, and after that, the laboratory investigation to reach to the specific diagnosis. You have to make the differential diagnosis. 75% your differential diagnosis is made on history and examination, and you have to confirm your diagnosis after investigation by an approach. First of all, the baseline investigation, simple hematology test, CBC with differential count, and especially the peripheral smear for any abnormal cells, atypical lymphocytes, or the blast cells, especially in case of leukemia. And there may be some abnormal cells also in case of lymphoma in peripheral smear. You can easily identify. Other functions include the renal functions, liver function for the organ functioning, and especially light, calcium, magnesium, phosphorus, especially in cases of abdominal lymphomas like non-Hodgkin lymphoma, especially the Burkitt lymphoma is the commonest type of the lymphoma which are present in the abdomen. So the patient may present it with symptoms of tumor lysis syndrome with renal derangement and with electrolyte abnormality. So you have to look for the electrolytes also. Chest X-ray is very important because if the patient is presented with an abdominal mass and you are suspecting the lymphoma, there may be a mediastinal mass or mediastinal lymphadenopathy. So you have to manage the patient according to that. You have to put the patient in proper position to prevent airway collapse or any emergency. Tumor markers are very important because you have to reach the specific diagnosis by a tissue biopsy, and it will be time-taking process. So you have to send tumor markers if you are suspecting specific tumor. They will help you in diagnosis. There are specific tumor markers, like for neuroblastoma and non-Hodgkin lymphoma, there is a prognostic marker that is LDH, lactate dehydrogenase, which is which is used as a prognostic marker. If the reading of LDH is high, then it should be considered as a bulky tumor or an advanced disease. In case of Hodgkin lymphoma, ESR is a very good prognostic marker and also a follow-up marker after the start of treatment. In case of hepatoblastoma, germ cell tumor, alpha-fetoprotein and beta-HCG are very important. If any one of these tumor markers is raised, and these tumor markers are done in serum, in blood sample, so you can get the results soon because the biopsy is taking time, approximately 4 or 5 days or 1 week. So if in case of emergency, when you have to start the treatment, the tumor markers are very important. On the basis of tumor marker, you can start the treatment or if you have a strong suspicion of that tumor. In case of neuroblastoma, urinary markers like VMA, vinyl metallic acid, and homovinylic acids in the urinary sample and also in the blood serum can be identified. If the levels of these markers are high, so you can have the differentials of neuroblastoma on the top. And other levels in the plasma like metanephrine, non-metanephrine, these are specific for the pheochromocytoma, but can be also raised in case of neuroblastoma. Ferritin is just a prognostic marker. It is elevated in case of neuroblastoma. Other tests like if the patient has ascites or pleural effusion, so you can have the fluid for the diagnosis. You have to do the detailed report of the pleural fluid or ascitic fluid and cytology for any abnormal cell. And if the number of the cells are high in the fluid, so you can make the cell block on the slide or immunohistochemical markers for the specific diagnosis, just similar to that of biopsy. And flow cytometry is a specific test for which you can identify the immunohistochemical markers, especially in case of lymphoma, primary abdominal. So you have to look for the primary site where the tumor is arising in the abdomen. So in case of an acute abdomen, X-ray abdomen is very important to let you know that is there any subacute or acute obstruction due to the mass effect. And the ultrasound is a very easiest and available modality that can easily identify the site, the size of the tumor, and the nature of the tumor, and you can easily make the differential diagnosis on ultrasound. So ultrasound abdomen and pelvis is the baseline investigation to identify the site of the tumor in the abdomen. And then the tumor markers, especially very important for the diagnosis of specific tumor. And after that, the specific imaging like the CT scan with contrast or the MRI abdomen and pelvis with contrast will give you the details of the tumor arising from where the tumor is arising, the extent of the tumor. The radiology will give you the differential diagnosis. And after the imaging, you have to discuss the imaging with the radiologist and discuss for the guided biopsy, either the ultrasound guided biopsy or CT guided biopsy. There are different ways of biopsies. If the mass is palpable, large in size, and easily for the guided biopsy by an ultrasound or CT, so this is very least method for the tissue diagnosis. In case if the mass is retroperitoneal, is not large enough, and you can have the laparoscopic biopsy for the diagnosis. Other scans, like specific scans like the PET-CT scan, which are highly recommended for the diagnosis of, especially for the extent of the disease in case of Hodgkin lymphoma. And now in recent studies, it is also used for staging work of rhabdomyosarcoma. MIBG scan, this is the specific scan which is used for the neuroblastoma. which can identify the different sites of the extent of the tumor where the tumor is metastasized. So workup for the secondary sites. First of all, you have to identify the primary site of the tumor, and after the radiology, you can make the differential diagnosis on radiological imaging findings, and then you have to do the metastatic workup for the extent of the disease and for staging purpose. And different tumors have different metastatic sites. So the tumors, especially the abdominal tumors, are metastasized to the lymph node, peripheral lymph node, like if the abdominal lymphoma, which may have the involvement of the lymph node in the neck, like cervical node, or the lymph node in the chest, like the mediastinal lymph node. So you have to do the CT chest and neck if you are suspecting an abdominal primary lymphoma. Other staging tests like the bone scan for the distant body metastasis, CSF-DR and cytology, especially in cases of lymphoma and leukemia, and in some cases of rhabdoma and sarcoma if they are paraspinal in origin. So you have to identify the extent of the disease by CSF-DR and cytology. Bone marrow aspirin is very important because some of the malignant tumors have the ability to metastasize to the bone marrow. In case of the solid tumor, we have to do the bilateral bone marrow aspirated to identify the disease, if the disease is metastasized to the bone marrow or not. So if we have a strong suspicion of malignancy, then we have to do the initial workup, and we have to refer the patient to the pediatric oncologist. And early referral is very important because the disease, if we have delay in referral, so this disease can extend and to reach to an advanced stage. If we are suspecting infection, if there is no suspicion of malignancy with a patient with abdominal distension, so you have to treat the patient appropriately. And if you are suspecting just constipation with abdominal distension, then treat it. If you are suspecting a non-malignant renal disorder or any disorder in the abdomen, especially for the renal disorder, you have to refer the patient to the nephrologist. The most important is the follow-up, because first you have seen the patient either in the pediatric clinics or with the general practitioners outside in the local clinics. So follow-up is very important because symptoms sometimes relieve with symptomatic treatment, but with time the disease may progress and presented in an advanced stage. So you have to follow the patient. If the patient is not improving as you expected, rethink your diagnosis and then refer to the appropriate place or a center or a doctor. If you are suspecting strong suspicion of malignancy, then do not delay in proper referral to pediatric oncologist. So now we have to go for the specific tumor sites and approach the renal mass. First of all, in history examination, you have to ask some questions like if the patient is presented with a flagged mass with abdominal distension, and usually in case of renal tumors, the mass are non-tender, painless, and sometimes there may be incidental finding by the mother during bathing, or if the child has symptoms, so they can talk to the doctors. They identify the mass and then refer to the proper center for further work. So in history, abdominal mass like flank mass, which may or may not be painful, there may be some associated symptoms like fever, hematuria, pyuria, or in physical examination, you have to look especially for the hypertension because the renal tumors are associated with high blood pressures. And in cases of volume overload due to the non-functioning kidney, there may be signs of congestive cardiac failure. And on examination, the palpable abdominal mass, you can identify the size, the volume of the tumor, If the mass is large enough, it may be more symptomatic. In lab investigation, you may found the polycythemia or hypercalcemia as a paraneoplastic syndrome. Then you, after history examination, you know that this is a flank mass. It may arises from the adrenal gland, from the kidney, or either from the gut of the abdomen. So you can have the simplest radiological imaging like the ultrasound. You can identify the site of the origin of the tumor, or either the tumor is looking benign or malignant on ultrasound. Then you have to go for further investigation like CT scan, abdominal pelvis, or MRI, abdomen and pelvis. If you have a high suspicion of malignant tumor on ultrasound, so you can go for the CT chest, abdomen, and pelvis at the same time to look for the secondary sites also. If you have a finding of a tumor in the kidney, looks malignant on radiology, so you have to refer the patient to the specific uh, doctor, like the pediatric oncologist, for further workup and the treatment. These are the some imagings of the ultrasound and the CT scan. It show the large mass which is solid cystic in nature, uh, present the right side, looking arising from the kidney with a claw sign that is the residual cortex of the normal kidney with the mass. This will give you a claw sign. In any renal tumor, you have the claw sign that is radiological imaging finding that the tumor is arises from the kidney. Sometimes the renal tumors may extend through the renal vein into the inferior vena cava as a tumor thrombus. So it can be easily identified on contrast imaging. Differentials in renal tumors, the 90% cases are the Wilms tumor. The age is under 5 years, and the Wilms tumor are of unilateral Wilms tumor. And in case of bilateral renal tumors, you have the differential of bilateral Wilms tumor, and that is also called as stage 5. In non-Wilms tumor, there are many different benign and malignant tumors that are very less in number and rare. In early infancy, congenital mesoblastic lymphoma, cystic partially differentiated nephroblastoma, these are two benign tumors that are present usually in age under 1 year, and their treatment is only the surgical treatment, nephrectomy, and they did not require any further treatment. Just follow up for surveillance with ultrasound examination, with ultrasound and clinical examination. Other rare malignant tumors that are non-Wilms tumor, including clear cell sarcoma of kidney, Ewing sarcoma is also called as primitive neuroectodermal tumor of the kidney, and a highly malignant tumor that is malignant rhabdoid tumor of the kidney. It is also present in very early age within 1 year. And other very less common tumors in the kidney that can be present, but they are very rare. As we have already discussed that some syndromes which are specifically associated with Wilms tumor like Weger-Dennis-Strauss syndrome, Beckwith Venus syndrome, these syndrome have a genetic association also. There is Wilms tumor gene abnormality that may lead to the Wilms tumor in these syndrome patients. So let's start the approach of the liver masses. If you are suspecting a liver mass on your history and examination, then the first modality is to use the ultrasound to identify is the tumor is within the liver or outside the liver. If the tumor is within the liver, and the findings of the ultrasound will identify that the tumor is benign in nature or it is malignant. And you have to do some baseline tests like CBC, liver function test, coagulation profile, and viral hepatitis serology, including hepatitis B and C, and the tumor markers, specifically the alpha-fetoprotein and beta-SCG. Alpha-fetoproteins is highly raised in malignant liver tumors, especially The commonest tumor, malignant tumor in childhood is hepatoblastoma. On imaging, if you have the appearance of a benign tumor, then the commonest cause of the benign tumor in the liver in early age is hemangioendothelioma. Is the vascular tumor or hemangioma. These are the vascular tumors usually present in early age, like within 1 year, and they are usually benign in nature. If they are small in size, asymptomatic, you don't have to do anything. You just have to follow the patient, refer to a pediatric oncologist for follow-up, for periodic follow-up with clinical examination and ultrasonography. If they become symptomatic and produces mass effect leading to liver dysfunctioning, you have to go for the guided biopsy, proper imaging, and then start the treatment. As we have already discussed, that if they are benign in origin and asymptomatic, you don't have to do further workup. You just follow the patient for the surveillance. If the patient becomes symptomatic, then you have to go for specific treatment after the biopsy. This is the list of some benign tumor and the malignant tumor. In pediatric age group, the commonest malignant tumor in the liver is hepatoblastoma. And after the hepatoblastoma, other malignant tumor is malignant rhabdoid tumor of the liver. Hemangioendothelioma is present anywhere in the body, but it can also present in the liver, and it presented in early age, and it also presented with a serious complication like the Kasabek-Merritt syndrome, in which there is a coagulopathy due to the trapping of the platelets within the tumor and leads to the thrombocytopenia. The patient may present with low platelet count, with petechial rashes, and with bleeding from the any site with an abdominal mass. So it is very important to identify the tumor because this is a large size and it is symptomatic. You have to go for the treatment after the tissue diagnosis. Or radiological imaging can also give a very important clue about the radiological findings for the diagnosis. In CT scan without contrast, these imaging appears as hypoattenuating within the liver, and they may be single or multiple. In contrast imaging, they will appear as a contrast enhancing hyperdense lesion within the liver. The most commonest malignancy in childhood from the liver is hepatoblastoma. Uh, is approximately 2/3 of all the tumors which are rising in the liver in childhood, and the median age of presentation is 1 year. Etiology is unknown, and there is an increased risk of hepatoblastoma in babies with low birth weight, and they are associated with these syndromes like Baffin syndrome and trisomy 18, and other syndrome like Simpson-Gulabi-Bahman syndrome. For the diagnosis, as we have already know that the history examination is very important. Then baseline workup, we have already discussed this, and the tumor marker AFP, which is very important. If the level of AFP with a large tumor is less than 100, this is a very poor prognostic factor, because the AFP should be in hundreds and thousands if the tumor is large in size. Viral marker, we have to do the serology of hepatitis B and C. In an older children's, there may be association of hepatitis B and C with secondary malignant condition in the liver with hepatoblastoma. So radiologic evaluation for the primary site, we have already discussed. CT scan abdomen, that is triphasic, is very important to identify the different phases in different phases like arterial phase, venous phase, and the interphase to identify the patency of the portal vein, hepatic veins, and the IVC in case of hepatoblastoma. After the guided biopsy, you have the differential diagnosis, you have the exact diagnosis that the case is of hepatoblastoma on biopsy. Then you look for the secondary sites for the metastatic workup. You have to do this chest X-ray or the CT chest for the pulmonary metastasis, and CT scan brain and MRI, especially in case of malignant rhabdoid tumor of the liver, because it can also have a simultaneous tumor within the brain. And bone scan is optional for the bony metastasis. Usually they don't go for the bone scan in all cases. Hepatoblastoma usually affect one or more of the contagious liver segments, and the staging is clinically on radiological findings. And the name of the staging system in case of hepatoblastoma is pretext, that is pre-treatment staging. And it goes from stage 1 to stage 4. And there is also a risk stratification on stage and annotation factors. Annotation factors are the factors which are the involvement of the tumor extrahepatically, like the extrahepatic lymph node in the abdomen, or like the which is positive for malignant cells in cytology, or if the tumor extends into the portal vein outside the liver in IVC through the and in the hepatic vein. So this is the extrahepatic involvement. And the pretext 1, 2, and 3 should be considered as low risk, and pretext 4 or with any pretext with the annotation factor should be considered as high risk for the treatment. So neuroblastoma, as you all know, it arises from the Neuroglass cells. It is the commonest extracranial solid malignant tumor, and 70% it originates in the abdomen, and 20% in the chest as a mediastinal mass, especially the anterior mediastinal mass, and 10% it may arise in head, neck. And it may present as a palpable abdominal mass or non-specific symptoms. And unfortunately, we have 50 to 60% patients with advanced stage disease with metastasis to distant sites. That is stage 4 disease. So the imaging findings of the neuroblastoma, we have the patient with abdominal mass, which may arise from the adrenal gland or either the paravertebral sympathetic chains or anywhere in the vitreoperitoneum. The soft tissue mass with abnormal echogenicity, and there may be there's a specific finding of calcification in neuroblastoma that is specific, and in CT scan, which can be easily identified, calcification can be easily identified on the CT scan as low attenuation within the mass, and the most important characteristic imaging finding in case of neuroblastoma is vascular encasement. Encasement of the aorta, IVC, and major branches of aorta is specifically identified in case of neuroblastoma. And this is not the feature of Wilms tumor. And technetium 99 label scan, that is MIBG scan, which is very important to identify the distant metastasis size of neuroblastoma. If a patient presented with an abdominal mass and the patient is unwell, sick, with electrolyte derangement, renal function impairment, so you can think of the lymphoma. The most likely type of the lymphoma which arises from the abdomen is the Burkitt lymphoma. And it is a highly malignant, highly proliferative tumor, and it is very well associated with tumor lysis syndrome. So we have to look for tumor lysis syndrome and also the management of electrolyte imbalance and the renal functions. Burkitt lymphoma can arise anywhere from the abdominal wall, from the abdominal lymph node, or may be associated with ascites and visceromegaly like hepatosplenomegaly. And sometimes it may present as an acute abdomen, like in emergency condition for exploratory laparotomy in case of acute intestinal obstruction like there may be intersection or intestinal obstruction due to a mass effect. We have to look for the chest X-ray and CT chest also for the mediastinal lymphadenopathy or mediastinal mass, because this is also an emergency, oncological emergency. We have to manage the patient in proper position to prevent airway collapse. And monitor of the tumor lysis syndrome is also very important. These are the CT scan imaging, which show the mass which is arising within the gut wall, and sometimes this mass may be associated with the mediastinal mass. So we have to go for chest X-ray and CT chest. Other differential that is less common for the abdominal mass, but the patient can present with an abdominal mass. Hodgkin lymphoma usually present with peripheral lymphadenopathy, and the duration of illness is usually prolonged. Patient is usually stable, and other symptoms like abdominal discomfort may be due to the visceromegaly, like hepatosplenomegaly, or enlarged intra-abdominal lymph nodes. Patient may have bone pains and cytopenias in CBC if there is bone marrow involvement, as in stage 4. These symptoms are the symptoms which are present in patients with Hodgkin lymphoma, like including fever, history of fever, daily single spike of fever for more than 15 days, and drenching night sweats, along with significant weight lost in last 3 months of illness. These are the B symptoms which are associated with Hodgkin lymphoma. Other association with Hodgkin lymphoma like autoimmune hepatitis, autoimmune hemolytic anemia, and nephrotic syndrome. Sometimes patient presented with symptoms of nephrotic syndrome, and on history examination, you may find lymphadenopathy, either peripheral lymphadenopathy or an abdominal lymph node mass. So you can go for the workup for the malignancy in case of nephrotic syndrome patient. This is secondary nephrotic syndrome. When you start the treatment of Hodgkin lymphoma with chemotherapy, nephrotic syndrome resolves itself. Hodgkin lymphoma, sometimes it is associated with the Epstein-Barr virus infection. As we have already discussed that ESR is a prognostic marker at diagnosis. If the value of ESR is high, so the extent of the disease may be more. PET CT scan is a specific imaging for the Hodgkin lymphoma that is nowadays recommended for staging of Hodgkin lymphoma. Bone marrow biopsy is also required for staging workup, as Hodgkin lymphoma has tendency to metastasize into the bone marrow. This is the PET CT scan image, and in PET scan, we have to do the CT scan without contrast also, and for the comparison of the masses at different sites. As in this case, the enhancing lesions that are present in multiple vertebral bodies and in the mediastinum, and also in the higher lymph node and para-abdominal lymph node, and also there is a huge uptake within the spleen. So these are all involved sites. In case of lower abdominal mass, we have differential diagnosis of germ cell tumor, which may arises from the gonads or either extragonadal, and which are of two different types, germ cell tumor and non-germ cell tumors, which may arise both from the gonads or either the extragonadal sites. Rhabdomyosarcoma is also a differential diagnosis if you have a pelvic mass or lower abdominal mass, which may arise from the soft tissue of the pelvis, anywhere in the pelvis, maybe from the bladder, within the bladder, prostate, or vagina, or vulva. Ewing sarcoma is also a type of malignant sarcoma, which may arise either from the pelvic bone or either from the pelvic soft tissues. Soft tissue sarcoma is a rare differential diagnosis. It can present as a pelvic mass. and the other is the colorectal carcinoma. Germ cell tumors. There are different types of the germ cell tumor which may arise from the ovary or from the testis or maybe extragonadal region. Specifically, the tumor marker alpha fetoprotein and beta HCG are very important diagnostic markers which can give a clue after the imaging or along with the imaging before the biopsy report. So we can early start the treatment in case of huge mass or with mass effect or any intestinal obstruction. Cyclopoxyl teratoma is also a differential diagnosis if you have an abdominal mass or along with that a mass in the lower back like arising from the coccyx or the sacrum, and it may be present at birth or may develop later in life. At birth, if the as shown in the figure, the mass, if it is present at birth, it's usually benign in nature, and it is mature teratoma of type, and you can easily identify it on imaging. There's a solid mass along with calcification. Sometimes mediastinal mass have differential diagnosis of germ cell tumor. Germ cell tumor can be present in the abdomen along with the mediastinal mass, and it appears as a solid mass on the imaging with calcification, and they are usually anti-mediastinal mass. Other differential diagnosis is rhabdomyosarcoma. Rhabdomyosarcoma on investigation appears as soft tissue density mass, and it is highly malignant infiltrating tumor. It can infiltrate into the surrounding structures and also eroding the bone. Uveic sarcoma or the peanut, it is also a malignant sarcoma which can true uveic sarcoma usually arises from the bone, or if it is arises from the extraosseous from the soft tissues, it may called as primitive neuroectodermal tumor. It may arise in the chest and is known as the asking tumor, and it may arises in the abdomen, in the pelvis with an abdominal mass, and it is associated with genetic abnormalities, that is Ewing sarcoma gene. So in the end, we have some cases for discussion. So let's start with case 1. A 2-year-old boy presented with history of painless abdominal mass in right flank for 2 months, and he also had history of hematuria. On examination, you found the anemia and raised blood pressure. So what further would you like to ask in history and look for in examination?
Participants, you can unmute your mic and answer the question so that it can be interactive. Anyone would like to answer?
You can also type their answer in the message.
Yes, definitely. Wilms tumor, Dr. Fatima.
Yes.
One of our participants have written. All right, very good.
Okay.
Thank you.
Okay. You have to look if the child is 2-year-old. So you have to first exclude any congenital anomaly in examination. As we have already discussed, these syndromes are associated with Wilms tumor. So you have to look for the congenital anomaly, and you have to ask the specific question and do complete physical examination for the local site like abdomen, and also for the systemic symptoms for systemic findings, and further evaluation by an ultrasound to identify the site, and it will give you the imaging finding that are Wilms tumor.
Dr.
Then you have to
Fatma,
go for Yes.
I'm sorry to interrupt. There's just one question in the chat box that is it necessary to know about the mass crossing midline or not? Like if the mass is crossing midline or not, is that necessary for Wilms tumor
No,
to
no, it is not necessary for Wilms tumor because as we have already read that the differences between the Wilms tumor and the neuroblastoma, that Wilms tumor do not crosses the midline as the neuroblastoma. This is not the fact. If a large Wilms tumor, if there's a large Wilms tumor with a large volume like 1000 ml or bulky tumor, it can crosses the midline and or either the neuroblastoma cannot process the midline if it is small in size.
Okay. All right. Thank you.
The important differential point in imaging for neuroblastoma and Wilms tumor is the vascular encasement. This is in case of neuroblastoma and not in the case of Wilms tumor. And there is a tumor thrombus in the renal vein or in the IVC, it is associated with Wilms tumor. On imaging, you can easily identify these features. So case 2, 3-year-old girl malnourished and she's looking pale with generalized lymphadenopathy. She had petechial rashes and bruising, periorbital swelling, and an palpable abdominal mass. These are the appearance of the eyes with ecchymosis, periorbital ecchymosis, swelling, proptosis, abdominal distension with petechial rashes. So what are your differential diagnoses?
So participants are writing neuroblastoma.
Yes. This is stage 4 neuroblastoma because it presented with symptoms like petechial rashes. There is bone marrow involvement, and there is involvement of the retroorbital tissues that causes orbital proptosis and the typical appearance of the raccoon eyes, which we have studied in our books. So other things we have to look for, because this is a systemic disease, we have to look for the small bony lumps which are present in the skin anywhere in the body. There may be symptoms of signs of Horner syndromes. There may be opsoclonus, myoclonus on physical examination, and tenderness due to the bone marrow involvement. So, case 3, 2-year-old boy presented with painless left scrotal swelling. The child presented with this complaint to the local doctor. He did the ultrasound. It showed a solid mass which is not separated from the left testis. So what are the differentials in your mind, and what questions you will ask in history, and what things you have to look for the examination?
So Dr. Fatima had
Yes,
asked
germ
three
cell tumor.
questions. Yes. Differentials, and what questions you would ask?
No, you don't suspect germ cell tumor at first. You have to have the differential diagnosis of some benign lesions also, like that hydrocele, hernia, inguinal hernia, or like infection, epididymitis, or orchitis. Either there is no signs of inflammation on this picture. First, you have to also think for the benign lesions, and then after exclusion of the benign lesion, then you have to think for malignancy.
Common things first.
Yes, because this is a small mass. If the mass is large, with involvement of the skin, with enlarged inguinal lymph node, then probably you would more think of the malignant tumor if the presentation is like that. Okay. This may be a germ cell tumor. So what is very important in next? Tumor marker, alpha fetoprotein. The alpha fetoprotein is raised at this age. This is 500 to 20. Then what is further evaluation? Imaging. You have to do the complete staging workup uh, that includes the CT chest, abdomen, and pelvis, including scrotum, for extent, because the testicular germ cell tumor, if it is benign in nature, it can extend. The locoregional lymph node is at the level of the renal hilum, para-aortic lymph node. So it can extend to the para-aortic lymph node at the renal hilum, and it may have the liver metastasis, pulmonary metastasis. So you have to do, if the alpha fetoprotein is raised, then you have to do the CT scan, chest, abdomen, and pelvis at the same time. And there is no testicular biopsy through the scrotum. It is contraindicated because it can contaminate the scrotal skin, and the tumor can spread into the iliac lymph nodes from the scrotal skin, and it may be the site of the recurrence after the treatment. So, inguinal approach for the biopsy or upfront orchidectomy if the tumor is localized. We can do orchidectomy upfront, either the disease is localized or either if it is metastatic. If the tumor bulk is more large, is the testicular tumor, you have to go for the orchidectomy first. That will give you the exact diagnosis, extent of the disease, and then you have to do the further treatment if it is required. If it is localized disease, stage 1, completely resected, you have no further treatment, just follow up for surveillance with clinical examination and ultrasound inguinal region. This is the picture showing the inguinal approach. That is the correct approach for the orchidectomy. The next case is 13-year-old girl presented with huge abdominal distension. Firm mass is palpable in the whole abdomen, and she had no other systemic findings. Age is very important, gender is very important, and then the abdominal mass. Large mass without any systemic findings. So what are your differentials? Yes, it may be ovarian tumor. Hodgkin lymphoma is less likely, because usually Hodgkin lymphoma is presented with peripheral lymphadenopathy. Yes, benign ovarian cyst. Yes, pregnancy. It may be a pelvic tumor. After imaging, you can short your differential diagnosis on imaging findings. So again, tumor markers are very important. In this case, alpha fetoprotein and beta SAG both are normal. Then we have to go for imaging. CT scan. It showed an ovarian mass. The imaging showed that there is a large mass arising from the adnexa, and it involving the whole lower abdomen. It is solid cystic in nature, and there is septation within the tumor. And these black areas, these are the hypodense areas which are usually cystic in nature. So this is on imaging. It gives an findings which are suggestive of the ovarian tumor. For the diagnosis, in case of ovarian tumor, you have to go for the staging scan at the same time, like CT, chest, abdomen, and pelvis, to identify any metastatic sites. And bone scan is also necessary in case of germ cell tumor for bony metastasis. So you can do the complete metastatic workup and then take a surgical opinion if and radiological opinion also if the tumor is completely resectable, and on radiological finding it looks like stage 1. There is no distal metastasis, no abdominal lymphadenopathy, just an ovarian tumor, and it is resectable completely. So go for upfront surgery. So you can have the diagnosis on the complete surgical specimen, and you can also do the staging. If there is a ascites in the abdomen, so you have to go for the ascitic fluid DR and cytology also to identify the disease in the peritoneum. There may be peritoneal deposit, maybe positive ascitic fluid cytology. It will indicate that this is stage 3 disease. After surgery, it will require further treatment with chemotherapy. So the next case, 11-month-old girl with constipation and lower back swelling. So what further would you like to do? So in similar way, tumor marker imaging studies. After imaging study, you will identify that there is a large sacral mass, and which is biopsyable. Do the guided biopsy of the mass to have the exact diagnosis, and go for the metastatic workup and surgical review. If the tumor is localized and surgically completely resectable, then go for upfront surgery. And another case of 1-year-old girl with protruding mass from the vagina and blood in the diaper. There is no abdominal mass palpable. What are your differential diagnoses? Think for the benign lesion first and then the malignant lesion. There may be a vaginal polyp which can easily be surgically resected, or if it looks malignant, do the imaging and do the biopsy of the lesion, and then metastatic work. 2-year-old boy presented with complaint of abdominal distension and upper quadrant mass, which was firm, non-tender. What are your differential diagnoses? Yes, hepatoblastoma, hepatoma. Hepatoma is very rare in childhood. Hepatoma actually is called as hepatocellular carcinoma, which is rare in pediatric age group. So we have already discussed the baseline investigation for the liver function test, and then the ultrasonography to identify the site of the tumor, and then exact imaging, which include the triphasic CT abdomen for the arterial, venous, and interface to identify the portal vein and IVC along with the liver mass, and then the guided biopsy. If the AFP is very high and imaging suggestive of the hepatoblastoma, then you can start the treatment before the biopsy report. And surgical opinion, you have to take the surgical opinion if the tumor is localized and small in size, and it is localized with no metastasis. So you can go for upfront surgery of the tumor. And if it is unresectable, large enough, so you have to give the chemotherapy to reduce the tumor size and then go for the surgery. Before starting chemotherapy, you have to go for the echocardiography and the audiometry, because we are using the chemotherapeutic agent which needs cardiac evaluation and audiometry. This is the last case, a 6-year-old boy, and had a history of abdominal pain and constipation for 2 weeks. And he presented with an abdominal obstruction, which was identified on evaluation. He underwent emergency laparotomy, resection of the intestinal mass with end-to-end anastomosis, and he had no follow-up after that, and again developed a mass in upper abdomen. Biopsy report was not collected at that time. What is missing in this case? Yes, the secondary cause of intestinal obstruction is intussusception. Yes, Burkitt lymphoma is the most likely diagnosis. These are the imaging which show intussusception with a sandwich appearance, and there is a narrowing of the lumen of the gut wall. What is missing in this case? The doctor has to ask the patient to follow up early with the biopsy report. So if there is a malignant disease or a lymphoma in biopsy report, he has to be referred to the pediatric oncologist early, so to start the treatment. There is a delay in the start of the treatment, so the patient presented with a recurrence of the abdominal mass. So thank you.
Any one of the participants want to ask any question to Dr. Fatima? They can unmute their mic. I think Dr. Fatima, everyone has understood completely, and there are no questions. Thank you so much, Dr. Fatima, for such an informative session. And there's just a couple of more things that I would like to say. Don't miss the case presentation that we have on 19th of June. We would be presenting cases from Ireland, UK, and Pakistan. So these would be very interesting cases, a lot of learning points to be gained from this session, and you can join us on Zoom. So other than that, yes, we have come to an end of our session. Thank you, Dr. Fatima, once again, and thank you to all of the participants. Keep in touch with PNMDP through our Facebook page, and do write to us at our Gmail address if you have something interesting to share with us on our website. Thank you so much. Allah Hafiz.
Thank you. Thank you so much. Allah Hafiz.
Allah Hafiz.